Hello, my name is Michelle Morand. I'm a precision cancer medicine educator and patient advocate, and I'm here today with Alexander Rolland. He is the co-founder of Cancer Treatment Options and Management and Liquid Biopsy Labs, and also the Cancer Guy on YouTube. Alex is here today to share some of his expertise with us. Something came across his desk recently, a new treatment option for people with metastatic EGFR-mutated non-small cell lung cancer. And so Alex has put together this presentation for those of you who are in this subgroup of cancer patients or know someone who is. This is really important information about new treatment options that are really going to benefit you greatly. So Alex, go ahead and tell us all about this.
Yeah, so this is all about non-small cell lung cancers driven by something called the EGFR mutations. And so this is a certain percentage of patients with this type of lung cancer have mutations in a gene called EGFR, and it causes this gene to stay stuck turned on. And basically that causes it to reproduce many, many cells and so on and so on. Many, many years ago, this type of cancer was actually the poster child for precision oncology. In fact, when I was in university, I remember learning about one of the first trials on this. It was called the Tarceva trial. This is the first generation of EGFR tyrosine kinase inhibitors. Basically, what a tyrosine kinase inhibitor is it goes inside of, it's a drug that goes inside of the cell, attaches to the on-off switch of the gene and turns the gene off, locks it in the off position. There's many ways these drugs work, so I won't get into that until later on in the show, in the slide. But what was really interesting about this Tarceva trial is it failed. And the reason it failed is because they didn't determine, they didn't just check the patients to see if they had EGFR-driven lung cancer or not. They just got a bunch of lung cancer patients and gave them the drug and said, let's see if it works. And of course, it failed. And it wasn't until after they did the subgroup analysis that they realized, oh, well, the patients with the EGFR mutations responded really well. And, the patients who didn't have this EGFR mutation obviously didn't get any benefit from it. These were first and second generation inhibitors. And then what was happening is patients were living a long time, but then they would get something called the EGFR T790M mutation. And this mutation basically caused a kink in the gene, and it prevented, what it did is it squished the binding pocket where the first generation inhibitors attached to shut the gene down. And so they weren't able to attach. And so it was a resistance mechanism to first and second generation inhibitors. Now, there's quite a few different resistance mechanisms, and there's many drugs that can target them. The key take-home point is that you need to know which resistance mechanism you have and then use the drugs that will target it. So I'm going to show a slide of various resistant mechanisms. On the left, this is resistant mechanisms that typically occurred in second-line treatment with Osimertinib, and on the right is first-line Osimertinib. So basically, as you can see, there's drugs for most of these mechanisms here, or a lot of them anyways. We're going to focus on specifically on a few resistance mechanisms that occur and a combination of drugs that work very well on them. But I want you to understand that really, if you have resistance to Osimertinib, it's all a matter of determining what the resistance mechanism is, and there's a good chance that there is a targeted drug for that resistance mechanism.
Okay, that's helpful.
Up until recently, options for patients who progressed on Osimertinib have been limited. Now, we were quite excited when Osimertinib came out. In fact, we had one of the very first patients on this drug at a clinical trial at Swedish Hospital in Seattle way back in 2016. And, prior to that, we were using various combinations of second generations, tyrosine kinase inhibitors and monoclonal antibodies. We were getting, some results, but when Osimertinib came out, it was a real game changer for patients that had a T790M as a resistance mechanism. So recently, there's been so many new developments in this. In fact, it's actually what we call an overcrowded arena, the EGFR resistance mechanisms, because as you can see, there's many different resistant mechanisms, but there's some ones that are much more common than others. Recently, there's this trial called the MARIPOSA trial. Based on the results of that trial, the FDA has approved a combination of a drug called Osimertinib, which is a tyrosine kinase inhibitor, in combination with a EGFR MET targeting bispecific antibody called amivantamab. And you could tell it's a monoclonal antibody because the last part of the name right here, MAB, stands for monoclonal antibody. And so I'll get into how this works, but this is for the first line treatment, and they're going straight to first line with this, of locally advanced or metastatic EGFR exon 19 deletions or exon 21 substitution mutations. So it's very specific, but what's interesting is it's used in the first line. And this was granted FDA approval under Project Orbis, which is a way of fast-tracking drugs via the FDA approval process. So about lazertinib, it's brain penetrant, so it has CNS activity. It is an irreversible EGFR TKI. I'll talk about that a little more in detail. And it targets the EGFR T790M, the exon 19 deletion, and the L858. These are oncogenic EGFR mutations. But importantly, it spares wild type EGFR. In other words, it only targets the cancerous versions of EGFR signaling and does not affect the normal functioning of the EGFR gene, which is important because you need proper EGFR expression. You just don't want to have oncogenic EGFR. It was previously approved in January of 2021. A little bit about tyrosine kinase inhibitors for the people that are interested in this. Basically, they interfere with the on-off switch of a gene. They're either going to be irreversible or reversible. So irreversible means they bind to it and they attach and they can't, they turn it off and that's it. Reversible means that once you stop taking the drug, then that signaling can occur again. So irreversible kinase inhibitors tend to covalently bind and block the ATP site, resulting in irreversible inhibition. Reversible kinase inhibitors are basically divided into 4 major subtypes based on the conformation of the binding pocket, as well as the DFG motif. I won't get into details of that. That's more for the biochemists and the doctors here. And they include type 1, type 2, type 3, and type 4 inhibitors. And basically we're just talking about how the mutation mechanism changes the structure. So think of the binding pocket as where the drug attaches to the gene and shuts it down. Different mutations will change that binding pocket in different ways. And so you want to be able to understand how that mutation's changed the binding pocket in order to use the right drug. While first generation inhibitors are typically reversible, second and third generation EGFR inhibitors, such as lazertinib, form covalent bonds with the EGFR receptors and therefore lead to irreversible inhibition of the pathway. In other words, they're less prone to treatment resistance, so they shut it right down. And that's the important take-home message. They're less prone to treatment resistance. Amivantamab, this is a new technology, very exciting, using antibodies. It's a bispecific antibody. That means it has 2 antibodies on it. And so one antibody attaches to the EGFR, and the other antibody attaches to what we call MET. And so MET is a common resistance mechanism, one of the many resistance mechanisms, but it's a different gene. So you can get resistance mechanisms in the EGFR gene itself, and you could also get resistance mechanisms in other genes that start driving the cancer. So this is one of those where a gene called MET or c-MET gets multiple copies of it and starts getting overexpressed and overactivated. But the mechanisms of this drug are different from the previous tyrosine kinase inhibitor. Basically, they attach to these 2 genes, or the cells, and what they do is they stop by immune cell directing activity, receptor degradation. In other words, by attaching to it, they cause it to get degraded, and also inhibition of the ligand. The ligand is something that attaches to a receptor and activates it. So they inhibit the ligand binding. A little more about this drug. So the immune cell directing activity. So this drug contains a binding region to attach to M1, M2 macrophages, which eat away at the tumor. It's a process called trogocytosis, which is a new one for me. And they also involve natural killer cells. So it's an arm of the immune system. And so in other words, with this drug attaching to the tumor cells, it recruits the immune cells. It also causes receptor degradation. So it inhibits the EGFR and MET tyrosine kinase activity. And once again, it also inhibits the ligand binding. So it prevents the activator of the receptor from binding to both the EGFR and the MET. So this is a very complex drug that has a multitude of different mechanisms, and it's a real game changer in technology and mechanisms of targeting oncogenic signaling.
It's exciting.
Yeah, so this is just a little slide from the drug maker of how it works. If you want to spend some time on this, you could go to the website and download this, but I thought I'd just put this in so it explains it in detail. So let's talk about the MARIPOSA study. In this particular case, they had patients with EGFR exon 19 deletions. That's an interesting mechanism. So what happens, genes actually have a area in them that tells the gene how long it's supposed to be active. And this is usually part of the gene structure. In this particular case, it's in the exon 19. And so when you delete the exon 19 of the EGFR gene, then the gene has no pre-programmed destruction mechanism. In other words, if it has the exon 19, in the exon 19 is the coding for how long the gene is supposed to be functioning under normal conditions. And when you delete that, basically it tells the gene, hey, you could go on forever. Yeah, so it's interesting because you'd think deletion of a gene would prevent it from working properly. It depends on what part of the gene gets deleted. And this part of the gene, if you delete it, it tells it to stay working.
Right. And as we know that means that it keeps making copies of itself, and that produces these masses that we call tumors.
It doesn't get degraded.
Okay. Right.
So normally when a gene is produced, it gets degraded after it's done its function. When you take out the exon 19, it doesn't have the signal to get degraded. So in other words, the mechanisms that attach to it and break it down are missing.
I know you've talked before about the concept of the Hayflick number. Is that relevant here?
Yeah, this is a similar concept, yeah, but it's applied to individual genes, and that's a great analogy. Thank you. So, and it's also for exon 21 specific mutations, and they're for locally advanced or metastatic non-small cell lung cancers in patients who have received no prior systemic therapy for advanced disease. In other words, they hadn't had a lot of treatment for their advanced disease. And so the combination demonstrated a significant improvement in progression-free survival compared to osimertinib by itself. And so basically what progression-free survival is it's the time period in a trial where 50% of the patients on the drug combination have their cancer recur. A hazard ratio, I've written that down in the bottom. A hazard ratio is basically the reduction in risk. And so a 1 means no change. Anything above a 1 means that the drug didn't work and the cancer grew. There is an increased risk, and anything below is a reduced risk. So a hazard ratio of 0.70 means a 30% reduction in risk. So in this study, the progression-free survival was 23.7 months. And it ranged up to 27.7 months in the combination versus only 16.6 for the osimertinib. So this is a massive increase in cancer-free survival compared to what was just recently considered, the golden standard of treatment for this type of cancer. And this is in the first line. And so what's really interesting is the overall survival were immature. So the overall survival is when 50% of the patients in the trial die from the cancer. And that hasn't been reached. So during the course of this trial, more than 50% of the patients were still alive. At 24 months, 74% of the patients are still alive compared to 69% for osimertinib. Side effects occurred in 49% because there are 2 drugs here. Versus 33% with osimertinib, so slightly more side effects. But many patients take osimertinib with hardly any side effects. So serious adverse events, which are the side effects, occurred in 2% or more. Pneumonia, serious rash, pneumonitis, which is inflammation of the lung lining, a pleural effusion, which is leaking into the pleura of the lungs. And these things are common in most patients that have, it's common in patients with lung cancers. When you have a tumor in your lung, you're likely to develop pneumonitis or pleural effusion or pneumonia. Fatal adverse reactions occurred in 7% of patients on Rembrandt, and 7% with osimertinib. So most of these sort of side effects are going to be things like changes in your nails, rash, musculoskeletal pain, edema, that sort of thing. So that is my summary of this combination.
All right, so let's back up the bus. I have some questions for you just to make
Yeah,
sure it all makes sense.
sure.
So, as you were saying, back 20 plus years ago when that first EGFR drug was developed, the researchers didn't fully understand the importance of stratifying patients. Thankfully, 20 plus years later, we absolutely know, and that's why, tumor testing is so important before you start therapy, because then you know what's driving your tumor and what drugs are going to serve you best or what you need.
Yeah.
You showed that image about the resistance. Maybe you could scroll back to that.
Yeah, yeah.
Obviously, and you made a point here of saying, hey, this might look a little overwhelming. It might look like there are lots of things that can get in the way. But we actually have targeted therapies for many of these. What I
Yeah.
wanted to actually know is, how do I, if I'm a patient and I'm looking at this and I'm thinking, okay, how do I figure this out? How do I find out what, if any, resistance mechanisms I have?
That's a great question. So resistance mechanisms can be genes that are stuck turned on, or they can be genes that are overexpressed, or they can be fusion genes, which changes, the function of the gene, or can also just cause overexpression of the gene. You have to look at the specific resistance mechanism. And, I see this all the time, is where doctors will just blindly give drugs to patients, hoping, that is going to work without actually even doing tumor DNA sequencing or RNA expression testing and not understanding the mechanisms. And that's one of the biggest problems, is the application of these drugs. Doctors should not be tasked with trying to figure out what the resistance mechanism is. That's not their training. That's not their job. Their job is large enough in keeping a patient alive and supervising them. Literally, we need a whole new discipline here to be able to educate and tell the doctors, here is a resistance mechanism. This is the drug that this patient needs versus your other patient who has a completely different resistance mechanism and needs a completely different set of drugs.
So how is that determined though? Like, if the oncologist were to get some data from somebody saying, here's your patient's resistance mechanisms, what would that person have done to get that data?
So the different tools that we use in this day and age are the tools that we've used in developing these drugs.
Okay.
They are the lab-based tools such as tumor DNA sequencing, which is taking the DNA of the tumor and finding out what the resistance, or finding what mechanisms are causing the problem.
Okay.
We now have a great tool for identifying resistance DNA mechanisms, DNA based on DNA mutations, called liquid biopsies. And so we can actually look for key mutations. So we actually, when we first started dealing with this, we developed a liquid biopsy to detect the EGFR T790M mutation. We also developed a liquid biopsy to detect MET amplification, because those are the two main mechanisms. So as soon as a patient became resistant to the first line, second line treatments of the EGFR inhibitors, we would use these liquid biopsies and find out exactly what the resistant mechanism was. Now there's many companies doing multi-gene liquid biopsies. Now, the thing is with liquid biopsies, and one of the problems I see occur quite a bit with these, is they are good for detecting resistance mechanisms. But if your cancer is not progressing, then you're not going to have very much tumor DNA in the blood. And that's part of the problem. So it has to be in the process of resistance in order to detect the resistance mechanism. Otherwise, you'll just be spending money on a test that gets you nothing.
Okay.
Also, we have developed a blood-based exosome-derived liquid biopsy that looks at RNA overexpression relative to specific tissues. So we can now take a sample of blood and we can see what those driving mechanisms are, which genes are overexpressed. And so a mutation doesn't always cause overexpression. It can cause the gene to stay stuck turned on, and then you'll see overexpression of the downstream signaling but not that specific gene, or it can cause, overexpression. And so having this panel of just under 21,000 genes that we can use to determine overexpression is a real game changer for us. It really adds another tool. And these resistance mechanism detection tools are advancing all the time.
Yeah.
But the best way, obviously, is if you have a new tumor occur, then you want to get a biopsy. There's nothing better than that, because then you can get that biopsy. You can say, okay, here's what's driving this new tumor. And, one of the common problems I see in cancer treatment this day and age, it's a real issue, is if a patient has a new tumor occur while on treatment, the doctors will shut down the treatment and say, okay, your treatment's not working anymore. We're canceling these drugs. When most of the time, it's just a breakaway tumor. In other words, the drug combination is controlling the vast majority of the tumors, but you have this one resistant tumor.
Yeah.
So instead of stopping the treatment altogether, what needs to happen is you need to target that specific tumor directly. And you could do that through radiation therapy in many cases. You could do it through surgery. You don't need to throw out the baby with the bathwater, so to speak. And so often when patients get a breakaway tumor, the doctors will stop everything. And then all of a sudden the patient has tumors all over their body because the ones that were being continually repressed by the treatment are no longer being repressed. I see this all the time, and it is a lack of understanding of cancer and its mechanisms. And the problem is medical doctors don't typically have the understanding. They don't have the expanded knowledge of cancer mechanisms and drug resistance mechanisms that somebody who only studies that does.
As a
And
patient,
so this is where this discipline is missing.
yes, and even worse, the administrators at the various federal, provincial, state, national, wherever you're living, cancer agencies, or the people who determine from a healthcare perspective for your state or province or country what will get covered, they don't understand this.
Not at all.
So I deal with it all the time in my role as an advocate, where because a patient progressed on treatment X, even when we can show the doctor why they progressed and how, keep them on this and add this, even if the doctor wants to write that prescription and wants and works to understand this, the administration who has to say, yes, okay, the patient can try this again, or we understand this was working and we just needed to add this, not take them off. It's practically impossible to get the people in those situations who ultimately have to approve the therapy to do so, because they just say, no, you've already had it and you progress, therefore, no, you can never have it again. And that doesn't mean that we can't help you get access to that drug, just so you know, but it does mean there's a lot of barriers and hoops, and you may have to pay out of pocket when you really shouldn't.
What's really sad about the whole thing in cancer treatment in this day and age, and this is common, this is a human frailty as far as I'm concerned, because I see this in many different disciplines, is it's an admin problem. It's not we don't have a drug for your cancer issue. It is a completely a logistical admin problem.
Yeah, that's right. Yeah, absolutely. And so really the fundamental point of this little sidebar about resistance mechanisms is it's not specific to non-small cell lung cancer.
Exactly.
Common across all types of cancers.
Mhm.
There are tests. Alex was talking about tumor DNA testing, which you must have for sure. At least 350 genes, ideally 550 plus.
Yeah.
And then this blood-based RNA test, this test that looks at every gene in your body, 20,813 of them that we know about, using that test to stay on top of any emerging mutations, to see what is now driving the bus. Because what Alex was saying is a very subtle point. Just because your tumor DNA test shows that you have a certain mutation, that does not mean that mutation is involved in your cancer. It does not mean, especially most important, it does not mean that particular mutation is currently a primary driver of your cancer. And most oncologists don't understand this distinction, and they don't have the tools to be able to figure out which is what you need the RNA expression test to do that. So oftentimes they will simply prescribe the one that showed up at the top of the list that they know of. And then when that doesn't work, as we've been talking about, because you may have had other mutations that were really primary drivers, or now you've developed a sensitivity to this, they're out of options, when in fact there are so many more options that can buy you many more years of quality life. Thanks, Alex. I really appreciate that. I think that extra little bit about understanding that and what to do about it to kind of get ahead of it. You don't want to wait until your treatment isn't working, essentially. You want to know what you're going to do next. And that combination of the DNA and the RNA testing is what gives you that information.
Yeah,
And then
totally.
ongoing monitoring with a blood-based RNA test is what makes sure you stay well ahead of emerging mutations and you're always on the right therapy. And that's what I want to say to you at home who are wondering, how do I apply this? How do I make sense of this? How do I make sure I'm always on the right therapy? That's how. So Alex is, of course, an expert in all this stuff. And if you'd like to have him and his team review all of your current medical records, what you're doing right now for treatment, everything that's known, any testing that you've already had done, you can book in a 1-hour consultation with him and his team, and they will do all that review and then meet with you and lay out all of the possible treatment options. In these consultations, over 90% of the time, Alex and his team are able to find a treatment option that is better than the one you're on right now without you having to do any additional diagnostics, just so you know. You can also join my course, Precision Cancer Medicine Education and Advocacy. It's called Cancer Just the Facts. Alex hops on a monthly basis and answers your questions and talks with you about some of the most current advances in your type of cancer. There's lots of other important information about precision cancer medicine and how to make sure you're applying it and that you understand the questions to even ask your doctor to make sure that they're doing their best for you. And then, of course, we've got the Cancer Guy YouTube channel. Lots of new information coming out all the time. Right now, we have about 800 videos on that channel about everything you could possibly imagine to do with precision cancer medicine and all different types of cancer. So
801 now.
801. So we are absolutely here for you. Our mission for 14 years, we've been helping cancer patients around the world identify the therapies that they need and then have the help they need to advocate for it. So we're here for you. Let us know how we can help. Thank you, Alex.